Hi, this is Jessica Kaplan, and this is my final physical assessment video for class. So first things first, you're going to come in, you're going to do hand hygiene. Hi, my name is Jessica. I'm your nurse today. What's your name?
I'm Antonio Narvaez.
And Antonio, do you prefer to go by Antonio, or do you have a nickname?
Antonio's fine, thanks.
All right, Antonio, can you tell me your date of birth?
July 24th, 1995.
And Antonio, can you tell me where we are currently?
Yep, we are in my home.
All right, and do you know who the President of the United States is?
President Joe Biden.
And can you tell me today's date?
I can't, but
What month is it?
this is December
And what year?
2022.
Perfect. So this is just assessing my patient's level of consciousness. He's able to make eye contact with me. He's alert. He's oriented ×4 to person, place, situation, and time. And he's also able to follow commands. So next, I'm just going to quickly do his vitals. And not forgetting that with vital signs, you've also got your pain assessment. So, Antonio, I'm just checking your temperature. So you're a little bit warm, but no fever. You're 98.1. And then I've got my pulse oximeter. I'm just going to check your oxygen. So this goes on one finger. This also checks your pulse at the same time, but I will be doing a full cardiac assessment on you. So you're 98% oxygen, which is good. That means you're breathing easily, and your pulse is 82 right now, which is also within normal limits. Next, I'm going to assess your blood pressure. So there's lots of different blood pressure machines out there for at-home monitoring. But I'm going to be using a regular size adult cuff. If my patient was obese, I would obviously be using a bigger cuff, or if I was assessing a child, I'd be using a child size cuff. This is going to go over. And you want this right above your brachial artery. And you want it tight, but not too tight. And be careful, if your patient has loose skin, you can actually pinch them, which is uncomfortable. And then I'm just going to listen with my stethoscope and cover your brachial artery while I squeeze the cuff. And you do want to make sure that your patient's arm is at heart level. Right now it's a little bit dependent, so it's going to affect the blood pressure readings. Good. So I got about 123/80. Good, that's within normal range. And again, I did say that his arm is dependent, so I'm not concerned about that diastolic number. That's still a really good number. Have you ever had any history of hypertension?
No, ma'am.
All right. So next, I'm going to do your pain assessment. Are you having any pain currently?
No, ma'am.
And on a scale of 0 to 10, what would your pain rating be right now?
Right now it's 0.
Okay. So again, with a pain assessment, you're going to want to look for nonverbal cues. If somebody's guarding or they have a pained expression on their face, they might have pain, but at this point in our assessment are uncomfortable about telling me about it, or they might just have chronic pain and maybe their pain tolerance level is a lot higher. So we assess your level of consciousness. Next, we're going to move on to assessing your cranial nerves. So far, I can tell you that you're oriented. You're able to obey my commands. Can you stick your tongue out for me? So your motor responses are intact. And also your speech so far has been clear. You haven't had slurred speech. You haven't shown any signs of aphasia where you aren't able to come up with the words like I'm having right now. And then we're just going to go through and we're going to do a head-to-toe assessment. So I'm going to assess your cranial nerves. Can you we'll assess we can do your cranial nerves 3, 4, and 6 first, which is going to be your extraocular movements and your pupillary response. So I'm going to stand about this far away and looking at the tip of my pen without moving your head, just moving your eyes only. Can you follow the tip of my pen?
Will do.
So as your patient is doing this, you're looking for any nystagmus. And perfect. There's no variation in the movement of his eyes. Next, I'm going to test your pupillary response, so I am going to be shining a light into your eye. So what you're going to do for me is you're actually going to focus off in the distance, and I'm going to shine a light in.
Do you want my glasses on? Off?
No, you can leave your glasses
Okay.
on. So you're going to look straight ahead. I'm just going to shine a light in. And so what you should see is an equal reaction on both sides. So the pupils are going to constrict, and what this is testing for is that the pupils are equal, making sure that they're round, they're both reactive to light. And then I am going to test one more thing, so you're going to look at the tip of my pen again, and I'm just going to travel in towards your nose, follow the tip of that pen. Perfect. And they're accommodating. Some abnormalities would be somebody's pupils are pinpoint, so meaning that they're less than 2 millimeters. Typical pupils are around 3 to 5 millimeters. Making sure that they're round, and again, any alterations in dilation versus constriction. If one eye is dilated and one eye is constriction, that might be an abnormal finding. Could be somebody's baseline. So we'll test some of the other cranial nerves. Can you close your eyes for me?
Sure.
So I'm going to have you smell something and just let me know what smell it is.
It's like a vanilla.
Perfect. So that's testing his olfactory cranial nerve, or cranial nerve 1, and you still have a sense of smell. Obviously you were able to follow my commands for your pupils, so your optic nerve is still intact. Now I'm going to just lightly touch your face and just let me know if you have any pain. Any pain?
No, ma'am.
Perfect. And then I'm going to actually feel right here, and can you clench your teeth for me? Perfect. And then can you open your mouth and resist against my hand? You can open it for me.
Oh,
Beautiful.
sorry.
So this is checking cranial nerve 5. So it's checking for sinus pain, checking for the ability to for mastication, and then I'm going to check your cranial nerve 7. So your facial motor skills. Can you shut your eyes really tight for me and open them? Can you smile? Can you frown? Beautiful. Can you puff your cheeks out? Beautiful. So he was able to do all of those movements, and they were equal on both sides of his face. Somebody who's had a stroke or who has some sort of neurological disease, such as Guillain-Barré disease, might not have the same equal movements on either side of their face. Next, I'm going to test your cranial nerve 8. So that's your hearing. So can you do me a favor and block your right ear off? I'm going to say 2 words. I'm going to whisper them. Let me know what they are.
Apple, banana.
Perfect. And can you do the same thing on the other side?
Cat, dog.
Beautiful. And then next we're going to test the lower cranial nerve. So we have cranial nerve 9 and cranial nerve 11. Can you stick your tongue out, or can you say ah for me? And stick your tongue out. Move it side to side. Beautiful. And then can you swallow for me? Wonderful. You're able to talk to me without any hoarseness or any alterations in voice, so I know that vagus nerve 10 is intact. And then one more, can you just shrug up against my hands? Beautiful. So that is testing cranial nerve 11. So while I'm doing all of these assessments, I'm also paying close attention to the color of his sclera and the color of the skin in his face. Does he have any pallor to his lips, or is there any cyanosis, that blue coloration? I don't see any evidence of jaundice, and it looks like he has really great perfusion. So next, I will actually, you can lay down for a little bit. So I'm going to do assessment of your pulses first. So I'm going to check your radial pulses. And again, you want to check bilateral sides because you want to compare and make sure that there's no areas where there could be occlusions. And both sides are about a 2+, which is perfect. Next, I'm going to test your pedal pulses. Pardon me, I'm probably going to block a little bit, but at the top of the foot. Good, and those are nice and strong, but not bounding. And also the dorsal medialis pulses. And while I'm down here, I apologize, but I am going to squeeze your toe, and we're going to check capillary refill, which is very brisk. You want it to be about 2 seconds. I'm also going to do the same to your hand. Beautiful. It is about 2 seconds on each finger, very quick. That's just showing that he has really good perfusion. You also want to check people's femoral pulses. It's going to be hard because he has clothing on and not a Johnny, but you would assess it's going to be right between the abdomen and the upper thigh. So in the crook of each leg are your femoral pulses. Next, while I have him laying here, so an important cardiac assessment is going to be looking for signs of edema. So in your lower extremities is typically where people get really bad edema. It could be pitting or non-pitting, and you would test it just by touching the top of the bones and seeing how quickly the skin comes back. He currently has no edema, which is really good. And then I'm also, while I'm doing this, I'm going to assess his skin turgor. So I'm just going to give a little light pinch, and his skin bounces back very quickly. It doesn't stay tented, which means that he's well hydrated and his skin is supple. So next, we'll move on to a cardiac assessment. So in this type of assessment, it's important for your patient to be supine. Reality is oftentimes in an office setting, sometimes the person is sitting up, but you do want them to be supine for this type of assessment, or in their left lateral decubitus position, so laying on their left side. Or they could be sitting up and leaning forward, and each of these different positions helps you hear how the different valves sound and different heart sounds. So I'll be using the acronym APE to MAN to help remember. There's a couple of different ones that you can use, but so you want to remember that the best point to hear your apical pulse, the best point to hear your aortic valve is the second right intercostal space. The best point to hear your pulmonic valve is the second left intercostal space. The third left intercostal is Erb's point, where you can really clearly hear your S1 and S2. The left fourth intercostal space is where you can hear the tricuspid valve the most. And then the fifth intercostal, left of the midclavicular line, so it's typically directly under the man's nipple, is where you're going to hear your mitral valve the best. This is also the apex of your heart, and it's also the point of maximal impulse. So I'm just going to do a quick listen. Sorry, I don't think this is that cold. No, we're good. So when you're doing an apical pulse, you actually want to listen for an entire minute. Because of this assessment video, I will not be doing that. But I'm just going to listen to each point. So I'm going to use the diaphragm of my stethoscope first. And again, this area is best to hear the aortic valve. And then the second left intercostal. The this area is best to hear the pulmonic. And then the third intercostal, Erb's point. Again, you're going to really be able to hear your S1 and S2, love dub. And then your fourth intercostal, this is where you're going to hear your tricuspid. And then the fifth, midclavicular, that's where you're going to hear your mitral. And this is the spot where you would want to listen for an apical pulse, just to make sure that the heartbeat is regular, they're not in AFib, they're not in a different arrhythmia. So alterations in sound, you could hear abnormal systolic sounds like early ejection sounds from aortic valve disease or pulmonary hypertension. And again, you would hear those in the aortic spot, or, you know, depending on which valve you're assessing, so your aortic, your pulmonic. You might hear abnormal diastolic sounds like opening snaps from mitral valve stenosis, or an S3 that happens in early diastole at the apex when they're laying in the left lateral, so if he was rolled over on the other side. This is that typical Kentucky sound when somebody's having heart failure, regurgitation, or fluid overload. And then there's also the S4 sound, so the atrial gallop, that sounds like Tennessee. And these types of sounds, you would want to use the bell of your stethoscope. Murmurs as well, you have pansystolic murmurs, midsystolic, and diastolic, and sometimes these are innocent sounds, but it's the turbulence of the blood flow through the heart, and it can mean mitral or tricuspid regurgitation, or aortic or pulmonic stenosis. So right now you're actually at a perfect angle to measure jugular vein distension. So you're a young man, you're well hydrated, your jugular venous pressure or your central venous pressure are equal to the pressure in the right atrium of your heart. So you're going to assess from the sternal angle. You can lean your head back a little bit, and you can turn your head that way a little. So you're going to assess from the sternal angle upwards, and at the point where you see no further undulation, which should be no more than 4 centimeters, you can relax your neck. That's how you would determine if somebody had jugular vein distension. You're going to see it. When people have heart failure, you can very clearly see that the vein is swollen. All right. Next, I'm going to do a respiratory assessment. So since you came in, you've been breathing normally. You know, I've been looking to assess work of breathing in your accessory muscles in your neck. They're not retracting, so I know that you're not having any dyspnea. I didn't do an official calculation. I would, you know, calculate for an entire minute how many respirations you have. But right now you're breathing normally between, you know, 12 to 20 respirations per minute. If you had an increased work of breathing or you were hyperventilating, your respiration rate would significantly increase. I'd see that work of breathing. You'd be using all the muscles in your chest and your neck to help you breathe, help you pull in air. Right now, your breathing is quiet. Some abnormal things with breathing are I might hear wheezing. Expiratory and inspiratory wheezes can be audible without using a stethoscope. The normal lung sounds are vesicular sounds. These are soft, low-pitched sounds heard throughout inspiration and into expiration over the whole lungs. Your bronchiovesicular are intermediate intensity and pitch. Those can be heard at the top of your lungs, and they're equal on inspiration and expiration. Your bronchial sounds, they're loud, high pitch over the mandibrium, which is this area, and they're heard more on expiration, and then your tracheal sound, which is a very loud, high-pitched sound heard right over your trachea. Some things that I may be listening for, if this person, his chest is not barrel chest, the diameter of his chest is normal for his height and size. He doesn't have a barrel chest. But if he had a history of COPD or asthma, I might hear some other adventitious sounds. So I'm gonna go ahead and take a listen to the anterior part of his lungs, remembering that his right side has 3 lobes and the left side only has 2. So I'm gonna listen in the upper. Can you take a good breath for me? Beautiful. So this anterior approach is good for somebody who's bedridden, who has trouble rolling over, but when you're doing a respiratory assessment, you really want to be listening to the back. It's just, you get clear sound. So if you want, you can sit up for me. Again, if your patient doesn't have any issues and they can do it on your own. In the back, you want to make sure that you're avoiding the scapula, because obviously you're not going to hear breath sounds over bone. So if you are able to see, I'm going to be in between the spine and the scapula to listen in the upper areas, and then as I get lower, I'll stay closer to the spine just because it will be easier to hear. And you're going to go in a bilateral approach because you want to compare sides. So if you can take a good breath for me. One more. And again, make sure you're giving people time in between if they have trouble breathing in. Beautiful. So his lungs are clear. Again, he doesn't have any COPD or asthma, so they're not diminished in the bases. I can hear all of those sounds. I don't hear any fine crackles, which happen in the dependent areas of the lung. Those are soft, high-pitched sounds. They're tiny explosions in the distal airways that cause popping. Coarse crackles, which are typical with COPD exacerbations, asthma, and pneumonia, are those popping sounds that can be heard in any lung region. You've got your wheezes, which are high-pitched musical sounds that are occurring over constricted airways. You've got rhonchi, which are lower-pitched musical sounds that typically clear with coughing. And then, of course, you have stridor. So this is your emergency situation. This is that typical pertussis sound, breathing in. It's a high-frequency, high-pitched musical sound. It's an emergency situation. That means an airway is being obstructed. You could also hear pleural friction rubs, that low-frequency grating sound that's caused by inflammation. And if you work in trauma, you might even hear mediastinal crunch, which is that precordial crackle synchronous with heartbeat. So I am going to percuss his chest. So when you're doing percussion, it's helping you figure out which areas of the lung are air-filled, which areas are fluid-filled, or which areas have solid masses. So a percussion sound of flatness could be pleural effusion. Soft intensity, high pitch. Dullness could signify lobar pneumonia, so it's going to be a medium intensity and pitch. A resonant sound is typical of a healthy lung. Hyperresonance might be your COP or pneumothorax. That's going to be a loud intensity, low pitch, and then tympany is going to be your large pneumothorax, so loud intensity and high pitch. So I'm just going to tap on your back a little bit. Good. I'm not at the best angle because of the bed, but I would definitely say that your chest is resonant. And we can do the front a little bit. Perfect. Sounds wonderful. All right. Next, I'm actually going to have you lay more flat. I'm going to reposition the pillow a little bit. so you can lay flat.
Thank you.
So now I'm gonna do a bowel assessment, and with your bowel assessment, you definitely wanna make sure that you are inspecting first, listening second, or auscultating, then moving on to your percussion and palpation, because what happens when you start palpating before listening, if that person didn't have bowel sounds and you go and move the air and fluid around in there, you're gonna get an inaccurate auscultation. So bowel sounds, you typically have 5 to 34 sounds per minute. It's best to start in your right lower quad. If you don't hear any sounds in that area, you can assess the right lower, right upper, left lower. Alright, so I'll kind of describe what I hear. Typically, you should be listening for a full minute in each quad. However, if you're not hearing any bowel sounds at all, then you know that some sort of obstruction is occurring. You can also have hypoactive bowel sounds, where somebody who has like Crohn's disease or an infectious diarrhea might be hypoactive because their body's trying to rid of themselves of whatever is passing through their colon. I'm just going to listen a little bit. And again, he's wearing shorts. You would probably be having them wear Johnny, and you want to make sure that you're assessing, not overclothing. You want to be skin to diaphragm of the stethoscope. Beautiful. So I did not listen for a full minute, but I can hear bowel sounds in all 4 quads. I also know that you just ate, so you have pretty good active bowel sounds, which is good. So next, you can also use, I shouldn't have taken this off, you can also use the bell of your stethoscope to listen for abdominal bruits. You typically don't want to hear any bruits in the abdomen. That would be a sign of arterial insufficiency or occlusion. So you can listen to the aorta. You can put the bell of the stethoscope here, listen for bruits, or you can listen to the renal arteries. A little bit further down, you have your iliac arteries on bilateral sides. And then even further down, again, you have your femoral arteries, which would be hard to assess because of the shorts that he's wearing. You can also listen for friction rubs of the liver on this side and of the spleen on this side, which would signify some sort of inflammation of those organs. So percussing the abdomen, because there's a lot of gas in the abdomen, but there's also fluids and fecal matter, it's mostly going to be tympanic sounding with areas of dullness. So obviously over a thick organ like the liver, you're going to have a dull sound, or if your person has a fecal impaction, you're going to have dullness. So I'm just going to lightly percuss. Perfect. So I would call those areas tympanic. That's hard to hear from where the camera is positioned, but you definitely hear mostly tympany. So again, the right side where your liver is, you would just slowly go up from the umbilical area to find the border of the liver. So that's the first area of dullness. Again, it's a little bit difficult to determine if that's where his ribs are or if it's actually his liver, but you're listening for that change from tympany to dullness. You can do the same thing on the other side, which is going to be hard in this position, but to find the spleen, and this would specifically be for if somebody was having an enlarged spleen or splenomegaly, you'd be able to, you're going to typically hear tympany, but if somebody had an enlarged spleen in that area, you would hear dullness. And then the same thing if he was sitting up This one is more percussion to determine if there's tenderness, but you would put your hand flat on their back over the costovertebral angle, and you're going to put your hand flat and you're going to percuss like this. And if they have any kidney tenderness, they're going to pull away from you or tell you that they have pain. So next we're going to do abdominal palpation. You want to start from a light pressure to a deeper pressure. So starting light, you're going to do about 1 centimeter in, and then deep pressure, you're going to do about 5 to 8 centimeters, depending on the thickness of your patient's abdomen, of course. So as I'm inspecting his abdomen, which you should be doing first, but I do it as I'm assessing, I note that it's flat, it's not rounded, it's not concave, it's not distended, there's no ascites present. And so as I palpate, I'm just going to feel for any masses, hard masses in there or anything. And again, as you're palpating, if somebody has any type of tenderness, whether it's regular tenderness or rebound tenderness, you're going to feel muscle rigidity. He's going to tense up against me, or he's going to guard it. He might even put his arms out, and that could be a sign of peritoneal inflammation. So this is the area where we would be assessing the position and size of his liver. He's asked me not to, so I'm going to simulate. Always listen to your patient. If they're uncomfortable with something, you don't do it. Patient comes first. So you would put one hand underneath, and then with your examination hand, you would lift the hand underneath up and push down into, and you should be able to feel the very edge of the liver. So it should be soft and sharp with smooth edges. If it's hard, if there's any displacement from its normal position, it could suggest hepatomegaly or some other type of liver disease. Again, the same thing with your spleen. So I would lean over. I'm leaning over in this position, but you would probably want to be on that side of the body. So you're going to put one hand underneath. So your landmark is the 6th rib on this side. Your landmark for the liver is the 12th. So 6th rib, and you would push in, and again, you would be able to determine if their spleen was enlarged. And for kidneys, again, I'm not going to do this one because we already established you're uncomfortable. So for the left side, so this side of the body, you can actually cup the kidney in between two hands and feel the edges of it and grasp it. So again, you would put one hand underneath and one on top and squeeze in. And you can't do that as easily on the right hand side. You can feel the differentiation between the liver and the kidney. But again, you would do the same thing, one hand underneath and one hand on top. And as you're doing that, you would ask the patient to breathe out. That's going to give you better ability to feel it. As we're down here, well, actually I should ask first. Normally I wouldn't be doing this much talking during an assessment because I would be asking you questions. I would be asking things like, when was your last bowel movement?
This morning.
Okay. And do you frequently have any issues with constipation?
No.
Okay. So, judging by my assessment of his abdomen, I didn't feel any bowel movement in the left lower quad. His abdomen was soft, so he's not having issues with constipation. And then I would also do a bladder assessment at this point, so I'm just going to lightly palpate in this area. So normally people have around 200 mLs of fluid in their bladder. Somebody that's having issues emptying, you might feel distension, and that would be at a point of 400 to 600 mLs in their bladder. Typically that's because they're having some sort of obstruction issue. Either they have benign prostatic hyperplasia, so their prostate is enlarged, or they might have urethral stricture, so they're unable to empty. Pardon me one moment. So when I palpated, he didn't pull away. He didn't tell me, ow, that's painful. He's not having any pain in that area. Pain in this area when you're palpating typically means that some sort of infection is going on. Oh, and also percussion over this area should be dull. So I am going to percussion because it's fluid filled. So next, while you're laying down still, I'm going to do I'll do a skin assessment, and then we'll pause for a second and we'll move on to an assessment of his motor responses, his sensory, and his his motor responses, the ability of him that he can move his joints, but we'll do a skin assessment. So when you're assessing skin, you want to look at color. Is the color of his skin normal for race, appropriate for race? Yes. Does he have any redness anywhere? I don't see any areas that look inflamed. If he had like a localized area of infection, it might be hot red. It could have an odor. There could be some sort of fluid coming out of it, some sort of drainage. Also, he does not have any signs of pallor or cyanosis. He has really good coloration to his lips. His fingertips have good color. They're not blue or white, as seen with venous and arterial insufficiencies. Same thing with his lower extremities. I don't see any areas of pallor, any redness. He's got very even hair distribution. A lot of times when people have arterial insufficiency, they lose their hair. He's got all his pulses were great and equal on both sides. No areas where I felt like there was any occlusions. Again, you're looking for jaundice. If he had a liver problem, is his face, is his, it's easier to see jaundice in somebody with fair skin than it is with somebody with a darker complexion. But you can also look at the sclera of his eyes, which are white, they're not yellow. You're looking at the texture of his skin. Is it dry, is it rough, is it smooth? It's pretty dry, it's smooth. He's not excessively sweating. We tested mobility and turgor by pinching his hand. There was no tenting. Temperature wise, and again, you want to compare bilateral sides whenever you're doing some sort of a temperature assessment, and that's appropriate. He's not too cold, he's not too hot. Again, with your skin assessment, you're going to be looking for localized areas of edema, which could signify either, a cardiovascular issue, or it could also signify, like say he had ascites in his abdomen. Is that a hepatic issue? Is he having issues with his liver? Hair is an important thing to assess. Again, I said he's got no areas of missing hair, no alopecia. And then next you're going to be looking for lesions. So freckles and moles. Does he have psoriasis? No. Are there any missing patches of melanin like vitiligo? Any nodules or cysts? He did share with me that he has a small, now that I'm not going to be able to find it, a small cyst on this side. It's probably a lipoma. I can't even find it. It's that small. Which is not abnormal, but again, you want to go and get those types of things checked out. Does this person have urticaria or hives? Are you allergic to something? And maybe you haven't figured out what it is. Do you have vesicles, which basically just means blisters? So, does he have a big burn on his arm because he accidentally burnt himself cooking? Or does he have blisters on his feet because he's not wearing the appropriate type of shoes? These are all important skin assessments. Vesicles could also be a sign of a virus, right? Like chickenpox, you get vesicles. Pustules, so common pustule you're going to see on somebody is acne. Not so common pustules would be like an abscess. You don't have any of those, you're lucky. Assessing the hands and groin area for things like burrows. Scabies is a pretty popular skin condition. It can happen to anybody regardless of where they live, or it does typically happen with people who are homeless. Also assessing hair for lice, and then any number of different things. You could have crustiness or scales. You're looking for scars. Has he had previous surgeries? Any excoriation, does he have scratches, lacerations? Specifically between toes, you're looking for fissures. Does he have really bad athlete's foot? And that's an area where bacteria can get in. And then on your people with alterations in mobility, you're looking for ulcers. So you're looking at all of your areas of a lot of contact, your bony prominences. So like your heels, sorry, I'm gonna touch your heels, tips of your toes, elbows are a common spot, and of course your sacrum and coccyx, which we're not gonna roll him over right now. But all your areas of a lot of pressure, you're looking for ulcerations. And again, paying attention to mucous membranes, it can tell you a lot about somebody's hydration status. And capillary refill as well. That's going to tell you a lot about somebody's cardiovascular status. All right, so now I'm going to pause the video very quickly, and I'm going to stand him up so that we can do a range of motion assessment.